Well, thank you for that debate about relapse myeloma. Let's move on now and talk about some emerging concepts in myeloma. And I think one that's particularly fascinating is the role of minimal residual disease testing. And I'd like to just start by having one of you perhaps describe for the audience the different technologies that are available and how they might be used. So Bob,
Sure.
set the stage for us.
Well, the most common technique now is the so-called next-generation flow, where right now on a bone marrow, you look at the aspirate, and for example, at MD Anderson, we look at 2 million cells by what's called flow immunophenotyping. So that's kind of like doing a fingerprint on each individual cell. So the advantage from a sensitivity perspective is that, number one, you're looking at 2 million events as opposed to maybe 100 or 200,000 for the standard flow. And number two, you can tell the difference between a normal plasma cell versus a myeloma plasma cell. So the sensitivity is much greater and it's more widely available. There is next generation.
It's also faster to get. You get the result the same day, essentially.
Correct. There is next generation sequencing, which looks
just
at.
Before you go into that, let me ask the audience, the panelists here. Are you using flow cytometry in your center?
Yes.
And is it the 8-color flow cytometry, the Europeans?
It is, yep.
What about a Duke?
We do, but we're not standardized with the operating system. But we do 2 million 8-color
You're doing basically
analysis.
some version of.
Yes.
It's called Euroflow because they developed it, the Europeans. Harry?
So we do the flow too at our center, but I would say our sensitivity is only 10 to the minus 5, unlike the NGF, which is 10 to the minus 6.
Next gen, but not routinely, not for routine everyday patients.
Flow cytometry, right?
No, next gen sequencing.
No, I'm only talking about flow cytometry just now.
Oh,
Are
so
you
we're
doing
not,
that at your center?
We're not doing flow.
All right. In Mayo Clinic, we have been offering flow, but like Harry, I think the sensitivity has been lower than we were hoping. We've just moved to the next generation, and we'll see where that runs. Sorry to interrupt, Bob. Let's go back to the second technology, which is next generation sequencing.
That's the other one which is now commonly used, at least on clinical trials, and the notion is that each myeloma patient has a different gene rearrangement that leads to the creation of the immunoglobulin gene in that plasma cell. And if you have a baseline sample that you can study, you can determine exactly what is that abnormality and then follow it through with subsequent samples. So the major downside is that the flow you can do at any time. You don't need a baseline sample,
right.
Whereas with the sequencing, you certainly would be very much helped by having that.
You need it, actually.
You need it.
Exactly.
Yeah.
So we have two competing technologies, and which one are you using preferentially, Cristina? Both of them or one of them?
Well, as part of a clinical trial, centralized, we use the next generation sequencing in our institution, and that is still unclear how you position the MRD outside of a clinical trial and what you do, with the information. But we do have the flow.
Okay.
Flow routinely, sequencing only as part of clinical trial.
Sequencing, I only do MRD for trials right now.
So
Don't do it routinely.
We've been using mostly sequencing. So it sounds like there's, even in this group, there's a lot of heterogeneity in how we're doing MRD testing. That's problem number one.
Right.
Let's talk about problem number two, which is how to use it. But before we do that, Harry, talk to the audience a little bit about what evidence we have that obtaining MRD negativity is helpful.
So we know there's a lot of things we know about MRD, and there's some things we don't know about MRD. The first thing we know is that getting to an MRD negative state by whatever cutoff we use is better than not getting to that state. So if you have a 10 to the minus 6 MRD, it means that we looked at 1 million cells plus, and there was no myeloma detectable in that person. And that is a good endpoint. That is an endpoint that people should aspire to, but it's not a cure. We also know that not everybody who gets there will stay cured at 4 years or 5 years.
So even at 10 to minus 6 negativity, people are still relapsing.
People still relapse, but your tendency to relapse is less. The other point to make is that people who don't get to an MRD negative state will relapse faster and will have a shorter overall survival if followed through time. However, there is a small percentage, probably somewhere in the 15 to 20% of patients who don't get to MRD negativity, in fact don't even get to a complete remission, who actually don't relapse at 4 years. So there is a small population there for whom it seems like getting to an MRD negative state is not imperative to survival.
Okay. All right. So what about high versus low risk? Does it make a difference?
So there's data.
High versus low risk genetic
Right.
patients.
Right. So there's data to show that if you're high risk, you should try and achieve MRD negativity. There's also data
Harder
to
to
show
get to,
it's
though,
harder to get to, and that's where you might want to do risk-adapted therapy. We're not quite there with the decision making, which is why I don't use this in routine practice. But there's also data now to show that there are a subset of myeloma patients who will become MRD negative very quickly, but they're the ones who become MRD positive as well. And that can be a very high-risk patient population. So there's a lot more to learn about MRD. I think it's an important tool that we have, which has prognostic significance, as Hari has pointed out, and the next few trials are going to help us decide how do we use this in practice.
So one of the most fascinating, Keith, in this year's ASH is the data from the Myeloma 11 trial in the UK, where they looked at MRD at beginning lenalidomide maintenance and then following through time.
Now,
so
to be clear, this was flow cytometry with
flow
relatively low
cytometry.
sensitivity, but go ahead.
But they did have about 20 to 30% of patients who actually upgraded their MRD response while on maintenance, and 4% who were just observed who upgraded, and then 10% who were MRD negative going in who lost somewhere during the course of maintenance. And it turned out that if you were MRD negative going in and sustained your MRD response as would be expected, those people tend to do the best. But if you lost it, just as Noopur pointed out, they tended to track with the people who were MRD positive at baseline.